Anthony Leeds, an academic physician with a special interest in overweight and obesity and the ways in which we can help people with that condition and the other problems that are associated with it. And today I'm going to be talking with my colleague in Copenhagen, Professor Henning Bliddal, who has worked extensively over many, many years on a range of arthritic conditions, but particularly on osteoarthritis in relation to managing it generally. And he's going to tell us broadly about the condition and then also about the experimental evidence produced in Copenhagen recently that enables us to be fairly confident that losing weight can be beneficial in some individuals. Henning, thank you very much for joining us for this conversation. Perhaps we could begin by a general review of the nature of osteoarthritis, causes, ways in which we can help people with the condition, comment on the fact that we haven't really got any way of preventing it from developing yet, as far as I know, or indeed treating it directly until it gets to the surgical stage. Perhaps you could give a little review of the background. Thank you.
Oh, yeah, sure. Usually we have regarded osteoarthritis as a straightforward degenerative disease developing over many, many years. But it seems that it does develop also with flares, bursts of activity that really cost something for the joint. And these are inflammatory driven. And the inflammation has several aspects to it. It's definitely inflammation that causes most of the pain. Of course, you have structural lesions in the joints if you are in advanced osteoarthritis. But most of the pain will be caused by the inflammation. And the inflammation also is negative to any kind of joint tissue. It affects the cartilage, the bone, the synovial membrane, and also the tendons, ligaments around the joint. You can see this, for instance, if you look at old arthritic hands, you can see that they get malaligned. They have various interesting skewnesses of the joints, and they get sometimes unstable. So it's of course a degenerative disease, but also it is characterized by flares and periods of inflammation. So to prevent this, you would have to look at the factors that are most important risk factors for developing the osteoarthritis, and this would be the female sex. You can't do anything about this, I guess. Not yet. People try, though. And age, of course, is a very relevant risk factor. This comes with age, so old people have more osteoarthritis than young people. And then you have trauma as a very important contributing factors. And all these, of course, some of it you can prevent, some of it you can't. If you do sports, you can do your best not to get into contact sports with large trauma. If you ski, downhill skiing, you will have to do it better, not to fall and injure your legs. And the knee is of course of interest to all of these sportsmen trying to prevent later osteoarthritis. But if you look at top sports people like the leagues, all these players will be my clients in due course. One factor that we know is very, very important for the risk of developing osteoarthritis is obesity. And this you can do something about, of course. And this is maybe the only modifiable risk factor for osteoarthritis that we know of. Once there, osteoarthritis, you still have an importance of obesity for the prognosis of the osteoarthritis. If you can lose weight, you've definitely reduce the load on the joint, but you also reduce some of the inflammatory loads that you might encounter in the joint. And we are pretty sure that obesity also contributes with some hormonal factors like adipokines that contribute to the inflammation in the joints and possibly the degenerative changes, because we see a relative risk of obesity about doubled for the hands, that is non-weight bearing joints, if you have a BMI above 30. So obesity is definitely a very important risk factor, and it's also a very important prognostic factor. And still, having worked with this for years, I'm I must say, a professor of osteoarthritis at the Copenhagen University, and I have come to the conclusion that the best way to treat and to help the patients with osteoarthritis, especially of the knee, would be to arrange dietary solutions for these people to make them lose weight, and possibly, if you can make them stay down, that is, maintain their weight loss later on, it will profoundly increase their abilities, their function, and decrease pain. And we know this is more or less exactly associated with the amount of weight loss you have. So indeed, this is the best you can do for the patients and the best you can do for yourself. If you have overweight combined with osteoarthritis, this is where you should indeed use your energy.
Yes, but the practical question though is how is this going to be achieved, and can people do it? And prior to the experimental work that you've done over the last 12 years or so, how successful were people in losing weight? Because on ordinary diets, it seems to me from my own clinical practice that people really did struggle to try to lose weight if they had osteoarthritis. So, for example, they might not be sleeping very well because of the pain, and they might be staying up late and watching television and eating more than they should be. Whereas if they had some extra way of helping them to lose weight, that may be beneficial. What was your previous experience, and then your experience as a result of the trial?
Well, we have been working with diets for years now, and it seems pretty much to us that if you are a partner in a group, all dieting, you have very good chances of getting the psychological support from the rest of the group, and with reasonable diets or even medications, you would be able to lose weight, even large amounts of weight, in a short while. It is then your responsibility to stay down, and this we know quite a bit about. And again, in our hands, we work with people with such lousy knees. I'm sorry to call them this. They have worn down many of the knees, and they have more or less the choice between diet and surgery for their knee trouble. And many people will definitely prefer trying the diet at first, at least, and then the last resort will be a replacement of the joint. And we're talking about knees in this case. And I think that belonging to a group, supporting you, will make you or give you a fair chance of maintaining the weight loss for years, as long as you can belong to this group for the whole period. And this
there are a number of different
for all the participants we know.
But there are a number of different types of diets that can be used in those sort of group environments, from ordinary conventional diets through to the type of diet that you used back starting in 2007, although actually you'd done a trial prior to that, of a formula diet for a short period of time, and then moving on to reintroducing food, and then maintaining the diet for up to 4 years in the case of your patients in Copenhagen. Can you tell us a little bit about how that work was done, that clinical trial which has produced that result?
Well, we've collaborated with various companies making these formula diets, and I think that it's of importance that they are not horrible, which the first ones we tried were. They tasted like nothing you would serve for your family. But later on, we have made acquaintance with several formula products tasting quite good, which is an advantage if you are to be on these diets. And in our hands, we use them for a very strict dietary introductory period where you've in phase 1 you lose a lot of weight, and then from then on it's more or less to maintain this weight loss. And during the intensive diet periods, you're not allowed any other meals than the formula diets. And this is quite important. I mean, if you break the rules, if you just take a loaf of bread one day, this day is lost, which we definitely tell the participants, and they adhere to the program quite well because they can see the results. I mean, we tried it ourselves before going into this and lost kilos, all of us, during just 1 week. So it's a very fast way of losing weight, and then comes the reintroduction of ordinary foods, which is just as important. But if you go down to the very low energy diets, you will definitely lose weight in a very short time, and it's great to see the participants having the joy of finally losing weight in such short time, and it's a motivating factor for continuing adhering to the program.
Yeah, and that was achieved when they tried ordinary conventional diets for some time before that. On the trial, of course, in the first 16 weeks, they lost between 12 to 13 kilograms, which is actually just over 10% of their body weight. So that's the sort of order of magnitude of weight loss that is achievable on that type of program. But then in the weight maintenance phase, sorry,
I know this is not only experienced by us. Several groups have repeated this, and it's more or less standard over the world that if you want a rapid weight loss, you do it this way. And in our hands, at least, it's important that they adhere to the program and they adhere to their group for support. And an interesting feature is also that they get healthier along the way. Most people being obese are more or less on diet all the time. They start every morning being on diet, and they manage to do well and eat healthy some of the day, and then they drop out of their own small program, somewhere between morning and night. And this causes a very unhealthy diet indeed. So they lack vitamins, they lack minerals, and this is also all these factors are supplied by formula diets. So they get healthier. We know this as a marker. We have tested vitamin D, and more than half of our participants are low in vitamin D at the baseline values, and they get healthier along the way, although they lose a lot of weight.
Yep. And also blood pressure was improved, wasn't it, as well, quite dramatically?
Yeah, all good things come with the weight loss, and then you'll just have to stick with it. So this is the important thing, to plan a program for long-term adherence to the weight loss.
Yeah. When it comes to rolling this out into ordinary clinical practice, though, or into ordinary experience of individuals, they can choose to do this type of diet themselves. But where have we got to with regard to guidelines in terms of, we know that practice among physicians and surgeons is determined to some extent by what is written in guidelines. How strong is the guidance in terms of what is in the guidelines? For example, in the United Kingdom, the guideline does very specifically say there's benefit in losing 10% body weight, benefit in losing 5% body weight, but there's no specific guidance on how to do this. And actually seeing it rolled into real life practice, there seems to be a little bit of a barrier to achieving that.
Yeah. Well, all the guidelines agree that weight loss is a basic treatment. It should be among the first things you advise people to do if they are overweight, obese, with knee trouble, hip trouble, it's in all the guidelines to prescribe a weight loss or to suggest a weight loss to the participants, the patients. How it's done is not part of the guideline, and I mean, we have experience with our program, and I'm sure that elsewhere you will find something else effective. There may be new medications like the GLP-1 analogs coming along, and it can be done almost anyhow you plan it if you just stick with a specific program. We have been very happy to do it with a diet. It seems natural to start there. But other people do it otherwise. So everything is okay as long as you get a healthy person out of the diet. I mean, dieting on your own with these very low energy consumptions is very, very difficult to do with any sort of healthy program, except if you use the formula diets.
In addition to diet, though, isn't it also important that they should actually work through a series of exercises for strengthening muscles around the knee, and actually ensure generally that there's an adequate amount of exercise? Because many of these individuals have spent many, many years slowly becoming less mobile, and the older individuals spend a lot of time sitting, and the limited number of body composition studies have been done suggested that the lean mass, the amount of muscle in the bodies of these people, is slightly reduced because of their inactivity. Is that correct?
Yes and no. I mean, at least our clients have such bad knees that you can't do exercise to any serious amount. You'll have to start with a diet, and when you're lower in weight, you may come into a program also with exercise, but evidence is actually against it. You can't expect people with that bad knees to do any amount of exercise. Truly, we are happy that people can walk, and we are happy that they make it better on the stairs to the youngsters they have to visit. It's all there, but actually to do strenuous exercise to heavyweight exercise is not part of our program. People are free to do it, but they have very bad knees, and if you put a lot of weight on these knees, you will wear them down. I know people do this differently in various sites and in various clinics. But our advice to people is definitely to lose weight first, and they then look at the exercise, whatever they can do later on.
There's also some other benefits as well, aren't there? Because I've spoken to some of the participants in your trial, and there was one individual who was delighted to be able to get back on her bicycle again after not being able to cycle for a while. And another one who reported that as a grandmother, she found that she wasn't able to get off the floor after playing with her children, and that she became more mobile and actually able to get up again after playing with the children. So there's an increase in mobility, and the people I've spoken to seem to be so much happier after they pass through your program. Is that your finding as well?
Definitely, and of course, all these scores, we also always ask people to fill in questionnaires and do a sum score of everything. We ought to have a happiness score, which would definitely mark the highest you can get, losing all this weight and being lighter for whatever. In one trial, we had people tested with a very advanced gait analysis before and after the weight loss, and we asked them, was it more troublesome to do the test afterwards? And they say, well, it's more or less the same. And then we put on a vest on them with pieces of lead in the vest, corresponding to their weight loss, and then we asked them to do it again, and then they really could feel the change. So I think that gradually people get used to moving better, having lost the weight.
Yes, and I think actually I was present when one of those trials was done, where you put the loaded vest on, and it was an enormous amount of weight that was loaded onto him. And the fellow said that he didn't realize how much weight he had gained until he'd actually taken it off. And having had it loaded back into the vest again and experienced that higher weight loss, he said he was never going to allow himself to get back to that previous higher weight. So it's a very good sort of learning experience for them, I think, which we don't routinely do in practice, do we?
Well, I always ask my participants and the patients how they manage bringing their groceries back home, and most of them really can feel the change. I mean, if you lose 14 kilos, it would correspond to a similar amount of liters of milk, whatever, and this is quite dramatic what they experience for change. One thing, though, with the program that we have been running, you talked of lean body mass, and of course, if you lose a lot of weight, you lose a bit of lean body. I mean, you use your muscles for ambulation, so you lose a bit of the lean body, but it's mostly fat. We have demonstrated that on DEXA scans, determining body compositions, and definitely if you go into a strict diet with formula diets, you'll mostly lose your fatty tissue.
Yep. Yes.
It's quite dramatic.
Yep. So in actual fact, the changes in the body composition seem to be all good. And in actual fact, you also tested the strength of muscles as well, didn't you? So in relation to body weight, the strength was maintained. So there's no worry about people becoming weaker after this type of intervention.
No, actually, we advocate that people get exercise and go for a walk, etc. The only thing we don't advocate is high intensity weight bearing exercises, because it must affect the joint. These joint surfaces are uneven. They are torn with crevices, with holes in them. So if you rub two of these joint surfaces together with a lot of weight, I'm sure that you'll lose more cartilage by doing this. But after weight loss, of course, every one of these worries, considerations will be lighter.
Yeah, good. Okay, that would be a good point at which to end for this week. So thank you very much indeed for discussing all of that very, very important information in relation to the nature of osteoarthritis and the ways in which weight loss can be beneficial. And I hope that we'll be able to come back to consider some other issues on the same unrelated topics on another occasion. Thank you very much indeed. Thank you.
You're welcome. Thank you.